I'm Dr. Andrew Weickhardt, sitting here at ANZUP 2023 and wrapping up after a great few days. We've been generously joined by Dr. Andrea Apolo, who's visiting and discussing issues to do with bladder cancer, biomarkers, treatment selection, and a fantastic couple of talks that she's given. So thanks so much for joining us today.
Oh, I'm so happy to be here.
Oh, it's been great that you came down. I'm just super happy given your expertise in the area, the research you've been involved in. And you gave a couple of great talks, which I think touched on areas that were really insightful in how we treat our patients in clinic today. And you talked about biomarkers yesterday. So what do you think are the biomarkers that clinicians could use to guide their treatment, as we sit here today, that we should be actually using?
Yeah, so unfortunately, a lot of the biomarkers have been tested retrospectively, but there's a lot of clinical trials right now that are currently incorporating these to make treatment decisions to see whether these can actually lead to a specific patient population that would benefit the most with the use of these biomarkers. Really, right now, we only have one targeted therapy, which is FGFR3 targeted therapy, and there's been a couple of efforts using different agents such as erdafitinib and infigratinib. I talked a little bit about the Proof 302 study using FGFR3 as a targeted agent. But the other biomarkers, I think they are, there's a lot of correlation with their presence and outcomes, but prospectively, they haven't always panned out, such as PD-L1 assay. And there's a lot of reasons for that. PD-L1 assay is a dynamic biomarker that changes with treatment. You literally give a treatment and then it changes. And so it depends also, there's heterogeneity into it. Depends the assay that you're using. So the studies that have incorporated PD-L1 as a biomarker in metastatic urothelial carcinoma unfortunately have not shown that it was a good assay to use to select and treat the patients, but it's still being incorporated and we're still learning as we go along. I did mention a couple of other assays. TMB is something else that I think is important, and we saw some data in a large cohort of solid tumor patients showing that TMB is important, but there's a lot of variability. It's a subjective assay. So I think there's a lot of important assays that are, I think, in the running, but yet right now not something that clinicians can incorporate yet into their practice.
So we've been thinking a lot about using ctDNA to guide decision making post cystectomy regarding the use of adjuvant immunotherapy, for instance. What do you think of the data that's been presented so far in that field?
I think I'm the most excited about ctDNA. It seems to really correlate with prognosis and how the patient does. And whether it's a predictive biomarker, we still don't know yet. It's been incorporated prospectively into several trials in the muscle invasive setting. So I think it's a really exciting biomarker. It seems to be very sensitive, and patients that are ctDNA positive do poorly, and it does change with treatment. So I do think it's a great biomarker.
Right. The atezolizumab study that Tom's leading, looking at using adjuvant atezolizumab in that study is based obviously on his prior experience. And that paper did seem like the benefit was really evident in that ctDNA positive group, which is what we'd expect. Right. I guess one thought that comes to mind is whether or not atezolizumab is going to be the best drug to convert ctDNA positive patients to negative and prevent any recurrence.
Yeah, you're talking about the INVIGOR-011 study, and that study is prospectively treating patients if they're ctDNA positive with atezolizumab versus observation. And I think atezolizumab is active, and we have seen its activity in the metastatic setting, and we have seen its activity in specifically in the retrospective portion of the INVIGOR-010 study of adjuvant atezolizumab, where it actually did convert patients that were ctDNA positive at a higher rate to ctDNA negative versus no treatment. So I do think that it's active. It's gotten a lot of negative press because of the negative trials, but I think it has a lot to do with the trial design. INVIGOR 211, which was the metastatic study, actually had a hierarchical approach and really treated patients based on whether they were PD-L1 positive. And those patients did so well that they just didn't have enough events to then go on to the second question of the intent to treat population. So I think atezolizumab gets bad press, but I think it's an active agent just like the other checkpoints.
Right. We had several patients on that study that did very well in the first line with single agent PD-L1 inhibition. Can I go back to just basic chemotherapy though?
Of course, yeah.
Adjuvant muscle-invasive bladder cancer. It's been a while since we saw a trial in this area that's recruited to a suitable number to ask a question: is dose-dense MVAC better than standard cisplatin gemcitabine? What do you make of the data that was shown at ASCO about the use of dose-dense MVAC?
Yeah. So regarding the VESPER study, which was really a perioperative study, neoadjuvant and adjuvant, but predominantly neoadjuvant, they did use 6 cycles of dose-dense MVAC versus 4 cycles of GemCis, and I think that's not fair. I think it's not a fair comparison. If you're going to give more chemo, it should have really been 6 cycles, and I understand that they were really trying to do the same timelines, which is 12 weeks of therapy, but not most patients couldn't get the full 6 cycles of dose-dense MVAC, and I totally understand it. So I think the trial emphasizes how active cisplatin-based chemotherapy is, and I think dose-dense MVAC is an important option for patients. But I still think GemCis is a good option for patients because not everybody can get dose-dense MVAC. And in that trial, they were a younger population than our regular bladder cancer patients. The median age was 63. The median age of our bladder cancer patients is 73.
Right. I did wonder, looking at some of the slides that were presented too, talking about the number of cycles, when they broke down the advantage and looked at the patients that only got 3 cycles of dose-dense MVAC did worse than patients that got 4 cycles of cisplatin gemcitabine. I mean, this is going to be retrospective. Those patients would have stopped because of some sort of toxicity and so forth. So it's a bit hard, but made me think you want to make sure if you're using dose-dense MVAC, you've got the right protoplasm to begin with. And if you've got any uncertainty, cisplatin gemcitabine may well be a much better option.
Yeah, I agree with that.
It's going to be fascinating, though, about enfortumab and pembrolizumab, which is an exciting combination based on what we've seen so far in the metastatic setting and the early cohorts of patients treated that we've seen data on in the first line. The muscle-invasive space, to me, that probably seems like the most exciting, potentially practice-changing area of the study designs in the immunotherapy space. What do you think of that?
Yeah, no, I think enfortumab vedotin in combination with pembrolizumab is very active in bladder cancer, and it's now received accelerated approval for the first-line treatment, specifically in cisplatin-ineligible patients. And I don't think it could have come in a better time because we're having a platinum shortage in the United States.
Right.
So it actually does become an option that we can use. But I still think that platinum-based chemotherapy is the best option so far until we have randomized phase 3 data from the EV302 study that should hopefully read out really soon. And yeah, so we have the EV304 study, which is EV plus Pembro in the muscle-invasive setting. I think that's going to be really exciting because if you have something active and you can move it to earlier states of disease so you can potentially cure the patient, I think that's terrific. I think the problem is that there is an adjuvant component to that. And does there really need to be? If somebody achieves a pathologic complete response to EV plus Pembro in the neoadjuvant setting, do you need to continue that therapy in the adjuvant setting? There's pros and cons. You want to be as aggressive as possible, but we are overtreating our patients. And we have a tendency to do that. We kind of go full force and then back off a little bit. So I think we'll need to do subsequent trials if this is active to see how we can dose de-escalate these therapies.
And to be clear, that adjuvant component, that's the adjuvant immunotherapy. They're not continuing the enfortumab as an adjuvant?
The enfortumab vedotin is being continued too.
Okay.
Yeah, for 5 cycles and the Pembro for 13.
Yeah, that's a lot of enfortumab and neuropathy that they might run into.
Yeah,
and that's a
in the muscle-invasive setting, when these patients, they may have been cured.
Yes.
Yeah,
that's going to be tricky. So let's go back to the metastatic setting. EV302, large randomized trial comparing platinum and gemcitabine to enfortumab with pembrolizumab. The data looks, from just the single the smaller cohorts,
Yeah.
as if they're going to end up with a pretty strong signal, especially in those cisplatin ineligible patients. The question on my mind is how many patients in the control arm are going to receive standard of care avelumab maintenance?
That's a great question.
To make you believe that the enfortumab pembro is a better treatment.
Yeah.
Because I have it in my mind that they're only going to, and this is not informed on anything apart from just wild speculation, that they're going to come up with a figure of 20 to 30% received maintenance of avelumab, and that leaves 70% of people who didn't receive what we now think is standard of care.
Yeah, no, that's a great question, and that's an issue. And initially, the study didn't allow avelumab maintenance, and they had to put in an amendment. But how many patients were enrolled before that amendment went through? I don't know the answer to that. So that's a great question. Is it really a fair comparison if the patients didn't go on to receive avelumab maintenance, but they're still receiving EV plus pembro until progressive disease? So it's a lot more therapy.
So it's going to be interesting, I think, as investigators and clinicians, when you look at data, I worry that what we're going to see is that classic, you see black, I see white, and we're going to treat completely differently based on just that interpretation rather than having some clear signal. But I think the most tantalizing thing about the EV302 potential of that EV combination with pembrolizumab is something we talked a bit about in your talk, was the durability of responses that we don't see with chemotherapy when combined with immunotherapy or even by itself. That, you know, from personal experience, and you probably had this as well, patients who tend to respond have these deep, durable responses.
Right. And that's the checkpoint component to it. We know that less people respond to checkpoint, but the durability is longer. So when you have a combination, you know, and it works, because this happened also. We combined chemotherapy with checkpoint inhibitor, and again, we didn't see additive effects, which we were hoping to see. And my theory is that these are the same patients, and basically you're not getting the additive effect. But when you do have additive effect, you get the durability, which is really fantastic. So yes, I completely agree with that. Yeah.
As clinicians in the US, you now have access to that combination. How's that going to affect your maintenance study that you're running, which is the Alliance trial?
Right. We have the MAINCAP study, which is a maintenance study of avelumab versus avelumab plus cabozantinib in patients that have already received platinum-based chemotherapy, and if they responded, then they go on to this study, and it's going to really affect it, I think, because if patients are getting enfortumab vedotin plus pembrolizumab in the frontline setting, then you're not going to get avelumab in the maintenance setting. So, you know, it's going to be an issue in terms of accrual. Yeah.
One of those things you can't predict as an investigator when you write these studies. What will happen?
That's happening a lot in bladder cancer in general. Literally, the mark keeps on moving, and the field is evolving, and it's really difficult as a clinical trialist to design trials for patients when the standard of care keeps on changing, and whatever you're using as the control arm or whatever you were thinking was going to be the prior therapy or the previous therapy are no longer the case.
Yeah, it's challenging.
Yeah.
It keeps you up at night as an investigator when you write these things and then have to make plans.
Well, this happened to me with the cabozantinib study, because we did the phase 1 trials of cabozantinib and nivolumab and cabo, nivo, and ipi, and we saw such great activity in urothelial carcinoma, 42% response for the combination of cabozantinib and nivolumab or the triplet, but there's no space for it right now because avelumab is being given in the maintenance setting, so that's why the MAINCAP study was designed. But there really is no, I mean, there's a small second line if the patient's got platinum-based chemotherapy, but with EV Pembro kind of pushing through, it may not be, there really may not be no space for that combination.
We didn't talk about it, but one of the trials that we're waiting still to see data on is ipi-nivo in the front line compared to standard chemotherapy. And we had patients on that study who did very well with immunotherapy, went on to live more than 3 years on study in complete remission. And I was sure this was going to be a positive study in the biomarker population.
Right.
Were you surprised when
I was. We're talking about the Checkmate 901 study that randomized patients in the first line setting to nivo/ipi versus, actually there was an arm that combined nivolumab plus chemotherapy, and then there was a platinum-based chemotherapy arm, and we got a press release saying that the nivo/ipi arm did not meet its primary endpoint, and this is for the PD-L1 high patients. You know, these drugs are clearly active, but I guess the question is, are they as active as platinum-based chemotherapy? And platinum-based chemotherapy is active in a greater number of patients, but the problem is the durability of response, right? So it's a greater number of patients, but the durability is short. For the checkpoint IO or IO combinations like ipi/nivo, it's in a smaller number of patients, but it's so durable. So
Right.
how do we optimize the sequence of these therapies? And we're still learning.
Right. We could talk all day about treating bladder cancer. You're such fond of information, and you've generously donated your time to come down here with your family. We'll wrap up so you've got time to have a good coffee, explore the laneways, get some sleep.
Australia is so beautiful. We're thrilled to be here. And I mean, the people are wonderful and the landscapes are so beautiful. We're so happy to be here. So thank you for having
coming
us.
to ANZUP.
Thank you.